Well, I'd like to welcome everybody to HHQI's Underserved Population Network quarterly webinar. I'm Misty Kevich, the RN Project Coordinator for HHQI, and we also have the following HHQI members with us. Shannon Wright, our Director, Cindy Sun, Crystal Welsh, Shannon Miller, and as RN Project Coordinators, and Misty Dyke and Andrea Lefke, our communication team. So we're glad that you were able to take time out of your day to be able to join us live, and for those of you that are joining us through the recorded webinar, welcome. We do have a few housekeeping measures before we begin. The slides are posted on HHQI's website, and Misty Dyke will put in a link in the into the chat box for you to be able to open it and get the slides for you. All participant phone lines are muted. You can use the chat box or the Q&A box to post your questions and comments for the speakers as we go along. We entertain as many questions as possible, so get them in early. There's a lot of great content today, so we want to make sure we don't miss your questions. We are very excited about today's presentation, Lower Literacy Approaches, Working with People with Dementia. I'll introduce you to our guest experts in just a few minutes. So I do want to let you know that there are free nursing CEs that are available with today's course. We'll give you the instructions at the end of the presentation for how to do that. The CEs are approved from the Alabama State Nurses Association through the American Nurses Credentialing Center Commission on Accreditation. If you have any questions related to CEs, please contact our mailbox, which is at hhqi@qualityinsights.org. And that's going to also be located on the last slide. Whoops, sorry about that. Let me get us back to the correct slide, sorry. Somehow I ended up, there we go. So I would like to introduce you to our two speakers today. We are very fortunate to have Jennifer Schlesinger, who is the Director of Professional Training and Healthcare Services at Alzheimer's Los Angeles. One of her focus areas is improving health literacy approaches with patients, especially those with cognitive impairments. She is the lead professional trainer for the organization. She's authored several curricula and trained thousands of professionals. Jennifer also has created online courses that have for both healthcare professionals and caregivers. And also with us today is Dr. Deborah Cherry. She's a clinical psychologist and the Executive Vice President of Alzheimer's Los Angeles, where her responsibilities include program development and foundation, government, and medical relations. She also serves on the clinical faculty at UCLA and has published many articles related to innovative programs for people living with dementia and their family caregivers. She's received many awards, and we're very honored to have both of those with us today. And at the end, I'll share another webinar that Dr. Cherry has provided for us that you will find very relevant to this topic as well. So without further ado, I'd like to turn it over to Jennifer.
Thank you so much, Misty, and welcome everyone to Lower Literacy Approaches, Working with People who have Dementia. We're really excited about this opportunity to share with you about plain language and lower literacy. And in today's webinar, we hope that you'll learn various lower literacy approaches that you can use when you're working with families who are affected by this disease. So today's learning objectives are listing 2 barriers experienced by many people with lower literacy levels, the ability to explain 2 ways to improve your agency's written materials, and then we will go ahead, Dr. Cherry will go ahead and describe how the IDEA tool can be used to improve management of behavioral symptoms for people with Alzheimer's disease and other related dementias as well. So let's begin by examining the literacy status of people in the United States. Less than half of Americans read at or below a 6th grade level, and over 36 million adults in the U.S. that's approximately 10% of our country, cannot read, write, or do basic math above a third grade level. Some pretty startling statistics. And low literacy affects many aspects of a person's life, and it certainly has a significant impact on health. We know that literacy is linked to health outcomes, and many social determinants of health are linked to literacy and to health literacy specifically. Almost half of American adults have trouble understanding and using health information, much of which because of lower literacy. And this is terribly costly to our healthcare system. Over $230 billion a year in healthcare costs are linked to low adult literacy, resulting in limited health decision-making capacity and also increased healthcare costs. We also know that direct care staff in many long-term care facilities have limited formal education, and this can certainly impact care practices. Consider the impact this all has on health. Everything from the inability to follow instructions from a doctor, inability to follow discharge paperwork, trouble reading medication labels, to the inability to read health-related brochures and apply information. When something says talk to your doctor about side effects from taking a medication, for example, can the person actually follow up and then have that informed conversation? People may struggle with being able to gather health-related information. For example, being able to go to a reliable website and use information to make an informed decision. Application of information is limited when someone has lower literacy. And people may also have a hard time with following up with their provider if they're unable to write down information, take notes, or something as simple as recording a telephone number. So what is a practical approach to dealing with lower literacy? Well, a plain language approach. As described by Professor Robert Eagleson in Australia, plain language is clear, straightforward expression using only as many words as are necessary. And if I can paraphrase, it's not language that's dumbed down. Rather, it is language that gets to the point and focuses on the message instead of the complicated language. Plain language makes sure that the audience actually understands the message and easily. What we've seen from our experience is that plain language actually benefits everyone. It certainly benefits people with lower levels of formal education, people whose second language may be English, aging adults. But in fact, in a world where people are flooded with health-related information that is often complex and often nuanced, plain language is really of benefit to everyone, and certainly for people navigating a challenging disease like Alzheimer's disease or dementia, it becomes increasingly important to get to the point and to understand necessary concepts. So understanding the literacy and also the linguistic needs of our community, Alzheimer's Los Angeles, our organization, has been very committed to transforming educational materials to plain language. I'm going to speak to you about the transformation process, and then Dr. Cherry will provide some concrete examples around a behavior management strategy that was transformed into plain language, what we call the IDEA strategy. On this slide, you can see some of the educational materials and programs that Alzheimer's Los Angeles has transformed into plain language. And a lot of this information is available on our website if you want to take a deeper dive. So Albert Einstein, he said, simplicity means the achievement of maximum effect with the minimum means. So let's talk about how this is actually done. We've used a plain language process that includes the steps of simplifying, testing materials, revising, and then, of course, retesting them again. And this is a process that occurs several times. It's not a one-time process. And we're going to discuss each step in this process and what the component parts are. So the first component of Simplify is to focus on the language itself. What words should be used? How will those words be understood? It's important to choose words carefully. Keeping language short and simple is important. And fewer syllables are easier to read when people have lower literacy levels. So think about the word frightened, for example. Could the word scared be used instead? Instead of 2 syllables, the word scared, easier, rolls off the tongue, 1 syllable. Using language that is personal and not too formal is also more appropriate for lower literacy audiences. Formal writing is often more complex. It's important to use language that's not loaded with jargon. In the world of dementia, we talk about the stages of dementia, memory care, speaking to an informant or a caregiver. We talk about the symptoms of the disease, such as sundowning or wandering. This jargon language gets lost on a lot of people and makes messages unclear. It's important to be direct and positive and avoid the lists of don'ts. Instead of saying, don't let the person with dementia go outside by him or herself, you can simply say, go with the person outside. In addition to simplifying language and words, concepts also need to be simplified to help lower literacy audiences. Remember, reading is not just about sounding out words, but it is about comprehension. It's about understanding concepts. I can give you a book to read, and you may be able to sound out each and every word, but if you don't understand the meaning of the words and sentences, there's really no utility in reading the text. So we focus on concepts that matter. By putting your most important message first and limiting the number of messages, audiences are better able to comprehend the concepts. Putting forward one idea at a time and avoiding lengthy lists and chunking information helps people learn concepts. For those people not familiar, chunking means giving people what I like to call bite-sized pieces of information that can be easily digested. What happens is concepts and information that aren't chunked can often overload us. And chunking helps readers, especially people who have a harder time reading. It helps make more logical sense of the information being presented to them. We also need to consider the graphics we use. Effective graphics and images help people learn and absorb messages. They help summarize and display information in a way that is easy for most people to comprehend. Using graphics, pictures, diagrams that are simple and are related to the words and concepts are helpful. In fact, sometimes graphics are more impactful than the text. We all have heard the saying of a picture may be worth 1,000 words. And so we certainly try to look at what graphics may help demonstrate the concepts that we're talking about, especially in our written materials. And of course, when we simplify materials, we're also looking at layout and the design as well. We need to look at how does it look. We want to focus on clean and uncluttered. It's easier to read. White space is less distracting and is less overwhelming. And white space also helps break information into chunks. We want to consider fonts that feel familiar and are easy to read. And we also want to consider font size. Can the audience actually see what is written? You can see on this slide an example of a font and font size that may be actually difficult to read, especially for someone who may not be familiar with cursive writing. And certainly when we're considering an aging population, can they see the font? And the colors that are used may not be very visible to someone who may have some visual impairments as well. So looking at dark colored text on white may be easier for them. So once we've simplified, we then want to test the materials that have been developed. Ideally, materials are created in original language. However, it is common that materials are created in English, and then sometimes, depending on our communities and their linguistic needs, we need to translate or transform those materials into another language. Our materials that were translated were then back-translated by our bilingual staff, and this is something our organization is very committed to, is not just translating materials, but really transforming them to meet the needs of our diverse communities and our diverse linguistic communities as well. So I'll just take a minute here to note that you may be interested in using translation services if you are developing materials. But it is important to keep in mind that materials will still need to be tested and further transformed. Having bilingual staff on your team that knows the local community and terminology can be very helpful. If an external translation vendor is used, it is probably not sufficient to assume they know dementia-specific words such as caregiving or Alzheimer's. It's also important to be cognizant of the vendor's ability or perhaps inability to bring down the literacy level of materials. So testing is extremely, extremely important in this process, and having bilingual staff who can test materials both in English and in other languages can be incredibly important. There are also readability scales or tools that are available. These are tools that calculate the number of sentences, words, syllables, and characters in your text, and then it plugs that information into a table or into a formula so you know the reading and grade level of your text. These are just some examples of various readability scales. There are many websites that allow you to enter text, and then the site will almost literally spit out for you the grade level of the material, which can be really helpful in gauging how well you have transformed materials into plain language based on grade level. And this is certainly something that our organization does when we are going through the plain language process, when we are testing our materials to see if we truly have brought them down to a lower literacy or a plain language level. And of course, focus groups are an integral part of the testing process. This allows you to truly know if the materials are plain language and if the messages resonate with your audience, with your target populations. So just as an example, something that came up in one of our Spanish-speaking focus groups was the need to include some examples on some of our caregiver tip sheets. So on a caregiver tip sheet that we developed around safety when someone has dementia, we talked about making sure that cleaning products are securely stored. But what we realized with our Spanish-speaking audience was saying cleaning products wasn't sufficient. They actually needed an example. They needed to hear the word Clorox or Windex, because cleaning products as a general term was not meaningful to them. And so when we transformed the materials into Spanish, we wanted to make sure that we provided a couple concrete examples that would resonate with that audience. And certainly that example could hold to any linguistic community, English, Spanish, or any other language as well. But the point is that focus groups provide a lot of insightful information that sometimes we as professionals may overlook, or because we're writing materials within our lens of experience, we may not be cognizant of. And then once materials have been tested, we go back and we revise materials. It's important to yet again look at word choice, to add examples as we feel they may be needed, to further simplify concepts, to consider the font size and color contrast based on focus group input, to reduce the amount of text, increasing that white space, making sure titles are clear, and when possible, if there are videos or other activities that we can add to educational programs to enhance the learning experience, those can be very useful as well. So here's an example of a caregiver tip sheet on bathing before it went through the plain language transformation process. And here is the document transformed into plain language. You'll see very noticeably some color, more white space, a graphic, information is chunked, there are very clear titles that are bolded, and there are very simple tips that are bulleted. Alzheimer's Los Angeles has created 12 caregiver tip sheets on numerous topics, as you will see here. They are all written at a lower literacy level, and they are available in multiple languages, in English, Spanish, Chinese, as well as Japanese. And you can download these tip sheets for free on our website, and we certainly hope that you will find them useful. So I've given you an overview of what this transformation process looks like to put materials into plain language. And now I'm going to turn over to Dr. Cherry so she can share with you a lower literacy behavioral management approach that has gone through, again, this transformative process that you can specifically use with the families that you work with and teach to other professionals.
So good afternoon, good morning, depending on where you are in the country. As Jennifer mentioned, I'll be talking about a plain language approach to managing some of the challenging behaviors we see in people who have Alzheimer's-related dementias. And, I wanted to start by showing you one of the very early approaches that many providers were trained in. It was called the ABC of problem solving, and it started with, the word antecedent, then behavior, then consequence. That's ABC, and it was obviously an approach that had a fairly high literacy level. This approach was often taken and put onto a chart, and caregivers, family caregivers especially, were asked to keep written records. When did the behavior happen? What happened before the behavior? What happened after the behavior? And, frankly, very few caregivers were willing or able to do this. Only the most obsessive caregivers, as a matter of fact, were able to do this kind of tracking. So it's a good start for behavior management, but it was not sufficient for working with most families. Here's the DICE approach, and this is an approach that's being used more recently. Also, excellent approach developed within a medical setting, and there's a growing body of evidence that's showing that it's effective. And this approach says, describe the behavior, then investigate the possible causes of that behavior. Create a care plan, a treatment plan is what this calls for, and then do an evaluation to see if the implementation of the treatment plan was effective. So again, this is an excellent strategy. I put a source for more information on it. It's probably better for educated staff, educated caregivers. Probably also works best in a clinic setting or a medical setting where there's a team doing the work. But when you're working with folks who are at a 6th grade reading level, it was not as helpful as we would have liked, and we decided we needed a plain language approach. And that approach is described here. It is IDEA, and I won't say that it's finalized. It has it is one that we use at 2 levels of literacy. So IDEA, the letters stand for ID, identify the behavior, being very specific. The E is for explore. Originally, we used the expression educate yourself, but in the focus groups with some families, English-speaking and especially Spanish-speaking, we discovered that educate yourself, which works very nicely for well-educated people and for professional people, was seen as derogatory. And so we've been using, in certain populations, the word explore for the E. and then adjust. We started with adapt and problem solve, and again, we're told that in our focus groups that adjust is probably better. This is very similar to DICE. Identify the behaviors like describe, explore, educate yourself is like investigate, and adjust is your way of creating a plan for dealing with the challenging behavior. This strategy and materials for it are available in English and Spanish, including an 1 hour to 90-minute class, which is going to be going up on our website soon. IDEA is a cognate in English and Spanish. It says the same thing, so it is a useful bit of language for both populations of caregivers. So let me go through the various steps slowly with you, as you might go through them if you were training your staff or if you were doing some education for a family caregiver. And the first step of this is identifying the problem, and this may seem obvious, but often it's not. Sometimes we're so busy reacting to a behavior from a client that we forget to stop and sit and really tactically look at what is the problem in the first place. So people just say, she's agitated, but maybe more specifically it is, this person is pacing, or this person is fighting me when I tried to give her a bath. So we're encouraging staff to speak with you or supervisors so that they can better understand the behaviors they see, and by identifying them more clearly, we can go to that next step about exploring what could be causing the behavior. So what is the behavior? Is it observable? When does it occur? Where does it occur? These are things that you don't need to put on a chart anymore, but you can compare it and chat with another person to see if other people see it the way you do in a more informal manner. Explore, educate yourself. And I have to say on many of the slides, because I'm working with a professional audience here, it says educate yourself. If I were doing this with certain populations, I would probably use the word explore. And exploring refers to understanding the causes or the triggers of challenging behaviors. Very essential message to you and to those you train is that behaviors are a form of communication. What is this person trying to tell you with the behavior that they're showing? If you can get that point across, many less educated care providers and caregivers, family caregivers at any literacy level, are going to be doing a better job of understanding what their relative is trying to communicate, is showing with a behavior. Part of exploration is figuring out whether the behavior is being triggered by an acute health problem, whether it's reflective of a person's psychosocial needs, or is the person feeling belittled or ineffective? Could the behavior be tied to something challenging in their environment, to a task that they're being able to perform that is too difficult, or to their difficulty communicating? Let me go over each of these and try to show you examples. And I think that Jennifer spoke earlier about the importance of examples. For all of us, for plain language teaching of other people on the management of challenging behavioral symptoms, giving examples is essential. So if you have an example on it, it goes much further than a full page of words. So we're going to start with explore health triggers. And there are many health triggers we see, particularly in our frail, older adult population. An acute medical condition or a worsening of a chronic medical condition can cause the person a lot of distress. And if they have dementia, they may not have the words to describe their distress. They may not be able to talk to you about a UTI, but they may show it in their behaviors. Medications are a major stimulant of behavioral issues in frail older adults and in people with dementia. And that can be polypharmacy, the starting of a new medication, and so forth. A person's pain or discomfort. I have here listed fatigue. An example that you might say to your staff is, have you ever felt so tired you couldn't think straight? That is the kind of fatigue that can cause people to have a lot of behavioral issues. Hunger, thirst, body temperature, all of them can cause the person to communicate to you discomfort because of their physical changes. And I have additional examples here, such as person getting poor sleep and being so tired, again, they couldn't think straight, sensory deficits, a challenge using their with mobility, and the others are listed. I'd love to give you an example here, and you should find your own examples. My example is a gentleman I worked with in adult daycare who was 62 years old. He was relatively early in Alzheimer's disease. He was charming and gentle and had a sweet sense of humor. However, he had a very anxious wife, and one day he came into the day center, and his wife said, I don't know what's wrong with him, but I think he's gone to the next level. And she described him being agitated, pacing, and when she approached him, he had almost reached out to strike her. In the day center, he continued having these behaving this way, and had an incidence of constipation. In this family, and this tells you the importance of doing something like the IDEA intervention. In this family, because of the wife's anxiety and her immediate belief that this was that he had moved to an advanced stage of dementia, she placed him in a nursing home within a day. A few days later, it turned out that he had had the flu, and when the flu resolved, he went back to baseline, only he was in a locked facility. And she was less willing than we would have hoped to bring him back home. This is a kind of, these health triggers can be really important for us as professionals and for the people we train to pay attention to. We call them red flag behaviors, and it's important to teach caregivers in plain language that a red flag is any sudden and unusual change of the person's behavior or mental state from baseline. So if you take someone to a doctor because they've changed suddenly, the doctor gets only a few minutes with the person who has dementia. They see them in a snapshot in time, and the physician says, okay, this is the dementia. Only the home care worker or the family member can say, Mrs. So-and-so was just fine last week. Now she's acting like this. The change in baseline can indicate a delirium caused by an acute health condition. And caregivers need to be taught what they are looking for. They need to, especially caregivers are often the eyes and ears, as well as family members are the eyes and ears, and can recognize these red flag behaviors. You can give your staff a mini lesson on what is a red flag behavior and how to identify it. Let me give you one example of that red flag behavior that comes from my own life. After my father died, my mother developed asthma. She was hospitalized for the asthma, and when she went into the hospital, the asthma made her very anxious, and she was put on an anti-anxiety drug. The anti-anxiety drug made her look depressed. She became sluggish and unmotivated. The doctors came in and they put her on an antidepressant. The next day, she looked really pretty out of it. She was not able to get herself to the bathroom or to manage her whatever the answers to the questions she was being asked. And when I finally arrived at the hospital, the physician said to me, well, at her age, what do you expect? It's a little bit of dementia. So knowing that this had been a change in her behavior from one day practically to the next probably saved her life, because by removing the antidepressant and the anti-anxiety drug, my mom and many other people can be brought back and was brought back up to baseline. And the side effects from these medications resulted in the individual still having asthma, but not having a diagnosis of Alzheimer's disease, which would have been inappropriate. So again, very important for you to teach this to your home care workers, that if you see a red flag is any sudden and unusual change in the cognitive, the mental state, or the behavior, that's a rapid decline from baseline. I'm going to move on away from education and talk about some of the environmental triggers of challenging behaviors that people should be aware of. And, you know, it is very hard for people with cognitive impairment to move to a new environment or to be cared for by someone new. And staffing changes can often trigger distress. A change in the routine that the person has, a change in the person providing care, can cause people to act out. It is best to have a routine and to have people stay in a familiar location if you want to avoid some of the behavioral problems that you see when they don't have that kind of routine. This is especially true when people are moved from a home environment to a nursing or assisted living environment. It's very disorienting and disturbing. But I think it's wise to warn staff providing home care that just being a new person in the person's life can cause them to act out. Not always, but it can. And the acting out is a communication that the person is not comfortable with the new person. That can change over time with reassurance and with additional exposure and familiarity. Other environmental triggers of some behavioral symptom changes in people with dementia are a very cluttered or crowded environment that provides too much input and stimulation, a noise level that is difficult to deal with, extremely warm or extremely cold temperatures, something that's extremely distracting, like the television going in the background at all times, which many people like to have in their homes, but can cause people with dementia to have a hard time knowing what's really in the room and what's on the television. So, you know, I know that sometimes people who are at home with a person with a dementia like that television because it gives them some stimulation, but I am here to say that it can be overstimulating and can trigger behavioral issues in some people who have Alzheimer's disease. Lighting glare also can be a problem. So again, you want to use examples when you're teaching people a lower literacy approach to managing challenging behaviors. And here's an example of a lady, let's call her Anne. Anne's very sweet. She's been easy to care for, but her family comes to visit for the holidays. And there are several kids, and the kids run around and yell. There's the noise of the television. There are kids playing computer games. So it is noticed that Anne starts to pace and tries to leave the house. Well, you ask yourself, maybe all of us would pace and try to leave the house with that much stimulation and noise. But if you don't want Anne trying to get out of the house and get away from all of this, the things that you might need to do is at least create a quiet zone for her or isolate the kids so that they're in one room while Anne gets to have the continuity of her normal environment. I'm going to move on to task-related issues and note that complicated tasks that show people with dementia what they can't do sometimes can be really disturbing to them and cause them to feel very distressed and to act out. These can be tasks that have too many steps, like someone who used to cook tries to cook a normal meal and realizes somewhere through it that they've lost their place and just cannot follow a recipe anymore. We have a fabulous tool on our website. It's a telenovela available in English and Spanish. It really shows this explicitly and is very usable for a lower literacy population. It shows in 4 very short segments of movie a grandmother facing dementia who attempts in one of the episodes to make soup for everyone. And what happens to her as she goes through the multiple steps. So it's really, this can be an additional tool for you. I'd also love to mention, or I think it's important to recognize that for anyone, being bored is also often the stimulus for behavioral symptoms. And if you have nothing to do, you probably might start looking around and try to find something to do. We have a gentleman whose wife complained that he was always trying to leave the house and that he had been lost on a number of occasions, and she couldn't keep her eyes off of him, especially in the afternoons. And when we did our exploration and educated ourselves, what we learned was that he was bored. He just had nothing to do, and by afternoon, he was looking for something to do. His wife tried something. She had him go out one day and collect the leaves in the backyard in a bag. And he worked on that for hours. It really helped her, cleared out the backyard, and he felt relaxed and had gotten his exercise through this. Let me also note that, these repetitive behaviors like leaf gathering, folding towels, sorting buttons, they are not only good on a particular day, but if the person is having the same issues the following day and their disease is advanced enough, you can do it again. And indeed, she did that leaf gathering exercise 3 times that first week until the leaves fell apart and more leaves had fallen down. And then she moved on, looking for something else that was a repetitive behavior he could take part in that made him feel useful. So you want to think about that. What makes people feel useful keeps them engaged, and repetitive behaviors are fine, and sometimes you can repeat them again and again. Communication can also be something that causes common challenges and common challenging behaviors to get worse. Have you see people with dementia and they can't express themselves, what we call expressive aphasia. We see it, but often a person with a difficulty speaking is also having a difficulty understanding. That's less visible. It's not even noticed by professionals. It's less understood still by many family members and people who are providing hands-on care. But it's an important point for all of us to know and for you to teach family members and hands-on caregivers. Also note that hearing difficulties are common in older adults and overlap with dementia. So just because you have dementia doesn't mean that you also might not have a hearing difficulty. And, I don't know if you've ever had someone call to you from another room and you can't understand what they're saying. And first you say, what? And then you say, could you say it again? And then you feel frustrated. A lot of times people with dementia who have hearing difficulties can feel frustrated. And again, not knowing to say, I can't hear, they might get more and more frustrated until it builds to anger, just like it would for you or me, and can result in combativeness. So be aware of that. And, again, these behaviors are trying to teach us, our efforts at communication. I'd also want to note that if English is a second language, people with dementia often go back to their first language, their native language, and lose their second language. I also want to mention the importance of understanding the meaning to the person of the behavior and of what they're saying. There are lots of times where people with dementia will say, I want to go home, or I want my mother. And, ask yourself, what are they trying to say to you? What does home mean? What is going to see your mother mean? The meaning of, people looking for security and reassurance is not necessarily appropriately dealt with when people are told that their mother is dead. Rather, they're telling you that they're anxious. That is what they're communicating. And you want to understand the meaning of that behavior to the person with the disease and also to their family caregiver, who may also be touched by whatever it is, be it a return to home when the caregiver knows the home they moved out of that house 10 years earlier. If the behavior is distressing to the person providing hands-on care, it's ever more important for them to come to understand what does it mean, and that it may not mean exactly what's being said, but may have an emotional meaning. IDEA is a simple rubric, a simple strategy to follow for understanding how to manage challenging behaviors. Again, the identification of the behavior and the educating yourself or exploring, it's really important to remember that behaviors are communication strategies and they're symptoms of the disease. They are not a person trying to annoy us, and indeed we have also on our website and soon with a facilitator guide a training program in English and Spanish about about using this IDEA strategy with caregivers so that they can understand that that behaviors do reflect communication, and that the person who has to change, the person who has to adjust or adapt is the caregiver, the family member or the paid caregiver. The person with dementia does not easily learn, and so the adjusting has to be done by the person providing care. You want the people who are providing care to understand what can and cannot be changed. There are parts of a dementing disease that are never going to get better. People's memory will not get better. They may ask questions again and again unless they are given something else to do that's distracting. Caregivers need to remember that they set the tone. If you become agitated, the person with dementia gets agitated. If you stay calm and patient and respectful, it's more likely that there will be a positive resolution to this behavioral issue, which is a form of communication. You want to try to avoid being demanding and negative, because the person with the disease picks up on your negativity and they will not respond positively to it. So things to think about: you can redirect the person, getting them to focus when they're going down one path and the path is disturbing because they are asking questions again and again, or they are trying to leave the home again and again, demanding to call their daughter again and again. Things to think about: you might want to distract the person, you can redirect them. I have always found that offering people ice cream for whatever reason is a wonderful distraction. People really enjoy it. You go off to another room and share the ice cream. Sometimes a caregiver gets so disturbed by the challenging behavior that there's almost a confrontation, and that is not a good adjustment to the person's attempt to communicate with you. So I don't think it's unusual for a caregiver or bad for a caregiver to, if it's safe, step out of the room for a moment and get their own emotions under control. But again, the one who adjusts, the one who has to make the adaptation is the caregiver, be it a paid caregiver or a family member. And finally, what I want to say is IDEA is something we all know that behavioral symptoms expressed by people with dementia have deeper meaning. as you teach IDEA to those who work with you, and I hope you will, you want to remember that behaviors are communications about what is going on in the person with dementia's life, and it's up to us to figure out what's going on, to explore, to educate ourselves. And we need to be the ones to make the adjustment to the behaviors, because the person with dementia can't be expected to change and meet our needs. They are, by nature of having a dementia, poor learners. There are a lot more materials about this on our website, and I encourage you to go to alzheimersla.org /professionals to see some of our caregiver tip sheets on particular behaviors, and some of our, and other parts of our website, you can see some of the curriculum we offer to family caregivers, but soon to come under professionals will be facilitator guides for teaching IDEA to caregivers, and a couple of other lower literacy programs such as home safety. So keep coming and taking a look. And now I'll turn this back over to my colleagues for question and answer.
Well, thank you so much, Jennifer and Dr. Cherry. Excellent information. We do want to make sure that if you will provide any Q&As for our participants today in the Q&A or the chat. There was a lot of great information provided, and I know most of us have stories. I've had people sharing stories with me personally about, oh, this really would have helped with my mother-in-law. This is great information. So keep providing some questions, and I will go ahead and ask some questions to get us started. I do know that there people were having trouble with the link. If that's the link for the caregiver sheets, the tip sheets, try it a second time. I found that I did it right away when it was there, but when I hit it again, it came right up. So I'm not sure what the little quirk is, but it did work for me repetitively, because that's the first comment I wrote down is the tip sheets are wonderful. And Jennifer shared a picture of, remember earlier in the presentation, what it looked like originally, how they modified it, made it simple, plain language, and then they added a little bit of a graphic with it. And there are great tips, not only for caregivers, but also for your home health aides in dealing and addressing with, anxiety, paranoia. The list goes on. There were many, many different ones. They're great. I know that I personally have been at work with my sister-in-law's mother in a nursing home, and some of the tips that are on those sheets are things that I've been trying to do, or some of the things that Dr. Cherry, you mentioned, were great new ideas that I'm going to use when I go back. So I think what Jennifer shared was excellent with us at the beginning. So I will, and we are getting a comment about, is the presentation available as a handout to share with staff members? It will be provided, the webinar in the next few days will be, the recorded webinar will be provided. I personally, as I listened, I thought this is very relevant for all of our clinical staff to listen to. It's great information, but I also think that our home health aides could learn just even from this presentation. But I do encourage you to go to the website, because there are great resources there, and the courses and training information is excellent. So I'll stop first with my little mini 2 cents here and see if, Jennifer, do you have any thoughts or comments that you'd like to bring up?
Just I find that when we're working with families and we're teaching the IDEA approach, providing the caregiver tip sheets is a nice complement to that. It gives them the ability to use a problem-solving technique that is easy, but also gives them the tip sheet that reinforces some of those possible adjustments that can be made, but also gives them the ability to be a little bit more strategic in what they may want to use from that tip sheet, given the fact that they've gone through the process of identifying the behavior and then exploring the causes and the possible meaning of the behavior to the person. But we find that when professionals teach families about the IDEA approach, and then we are in the community also teaching IDEA, it gives a similar language for families to know and understand, and to be hearing it from different professionals can be really helpful as well.
Wonderful. And I think we could take that even as we develop collaboratives within our community with other healthcare providers, be it a care transitions between hospitals, nursing homes, and other outside providers, or working with improving our relationships with physicians. So we could try some of the strategies, share those with the physician practice, so we're all communicating and working off of a common care planning and an IDEA type of format. So there is great work that could be used for the IDEA.
And we find that a lot of our providers really appreciate having the plain language caregiver tip sheets, because it gives them a tool in their toolbox that's very easy for them to hand over and know that their patients have better access to the concepts and the materials that they are giving to them, as opposed to giving them something written at a 12th grade literacy level that, you know, they may not understand, or they may just, you know, throw on the table. So
absolutely.
If I can add to what Jennifer said, there are now actually 15 of these tip sheets and more in development. And if your home care aides speak Chinese, Japanese, Spanish, or English, we have the tip sheets in those currently in those 4 languages. And again, under on our website, under professionals, there will soon be facilitator guides for delivery of a training that teaches staff about the IDEA, staff or family caregivers about the IDEA strategy for managing challenging behaviors. It's not up yet, but it will be.
But it's
soon.
coming. Wonderful. And
the class is now called "Are They Doing That to Annoy Us?" But we are working on the. You know.
Okay, and one other point I do want to bring up from your presentation, Dr. Cherry, that I think is really important as home care clinicians, is really looking for those acute changes in cognition, being that it could be delirium. And we've recently, a few months ago, did sepsis webinar, really trying to take a look at what are the signs and symptoms. And in the past, it's always been thought of, well, home health, that's really an acute care problem, not a home health. But 80 or 85% of sepsis symptoms appear when the patient's in the community, in the home. So we have to help. We know a lot of our patients get severe UTIs, et cetera, but we have to really be attuned to what their baseline is and looking for those red flags. So I'm so glad that you brought that up today, Dr. Cherry.
I think if people walk away with just that message, that people, an acute change from baseline is a red flag, that, you know, that message actually can save lives. Very important.
Yes, it absolutely can. And we do have a resource and a webinar on sepsis. So if you're interested, you just need to go to, you know, actually, Misty D, while I finish these last slides, do you think you can go ahead and grab, that was a national presentation that was just done a couple months ago. So we'll see if Misty D can get that in while I finish up these last couple slides. We do have some resources. These are some of the university courses that are applicable to the work that was discussed today. The Creating Dementia-Capable Systems of Healthcare is one that Dr. Cherry provided. It is really a framework of looking at what you're doing at an organization to really be able to provide a more capable and functioning dementia care program at your organization. So the PowerPoints have links to everything. Our next up webinar will be in April the 18th from 2 to 3 p.m. Eastern, and the topic is going to be on caregivers again, and this is related to looking at the value of caregivers with this ever-changing healthcare environment. Our guest expert is Warren Abert. I have to make sure I get his pronunciation correct here. He's the Chief Executive Officer of the Home Care Association of Louisiana and an Associate Professor at Loyola. He's been a HHQI supporter and a partner for over 12 years, and he's an expert and lives with true life situations. But he's going to talk about some of the policies that are changing that's going to really help. But he's going to talk about how you have to learn to value your caregiver in a whole different approach, because we're moving in a different environment of healthcare. And we can be very advantageous to the care and our outcome work. So it's not available yet to sign up, but you can subscribe to our mailing list and select the underserved population. And now that we're at the top of the hour, I do want to let you know for the continuing ed, you just have to finish like 15 minutes of just really doing the evaluation and doing a reflective question. There is a step-by-step flyer that's on this slide in the handouts, and you'll also receive that in the email that will follow post-course that you just need to go in, enroll. If you've enrolled in the university before but can't remember your username, send us an email. We'll look it up for you. We don't want you to have two accounts. We want to keep all your certificates there. There'll be nursing CEs and a certificate for those who just attend. So we want to thank both Jennifer and Dr. Cherry for sharing this great information with us today. We want to thank you for attending. We hope that you find this valuable for your organization, and perhaps will even just use the recording as a way to continue to share within your organization or take tips that you've learned today. So again, we thank you from HHQI.